Hey everybody, welcome back to the ECG channel. My name is Reed. Don't forget that you can download the PDF of today's ECG down in the description below and make your own notes and follow along and save it for later to study with your friends. So let's go ahead and get started with this one. This is a fun one. So the first thing I'm going to do is look at the forest, and the trees of the forest are my QRS complexes. So maybe I'll start down here in lead 2. You can see I've got a narrow complex QRS that is very regular. It stays regular that entire strip, but it looks a little bit slow. So what I'll do is I'll calculate the rate. I'll find a QRS that lands on a solid line. And what I'm going to do is I'm going to count the number of large boxes. And so I've got 1, 2, 3, 4, 5, 6, about 7 large boxes. And so 7 boxes. So we can do 300 divided by 7 to get our rate for this rhythm. And that is 43 beats per minute. So we've got a bradycardia, and it appears that it's a bradycardia that's originating at least from the AV node or higher, right? Because it's a narrow complex bradycardia. It tells me that we're taking that His-Purkinje system of rapid depolarization if the duration of my QRS is narrow. So what are some differential diagnoses for bradycardia? Right, we need to develop a hypothesis and we need to work through it. We need to have a systematic approach to this. Well, we could have a junctional bradycardia. We could have AV node blocks. We could have sinus bradycardia. Okay. We could have SA exit blocks. Right? So we're starting to work through this a little bit. I see that before my QRSs, there seem to be P waves. So, okay, we know that conduction seems to be coming from the sinus node. I don't really see any ectopic or early P waves that are not being conducted previously, but let's take a look. All right, so let's look at what our atria is doing, and so we're going to evaluate that P wave a little bit closely. So when the P waves do occur, you can see that they're maybe ever so slightly upright in lead 1, just a little upright in lead 1, but more isoelectric than not. And look at the negative leads. My P waves are negative in my inferior leads. And so this tells me that my P wave morphology, you notice it's upright here. You can see that my P wave morphology is upright in the superior leads, but it's negative in the inferior leads. That tells me my P wave is going somewhere in this direction. And so that means that this is an ectopic. This is an ectopic P wave. Okay? And you notice that these ectopic P waves are being what? They're being transmitted via the AV node to these nice normal QRS complexes. So we've got an ectopic P wave. So at this point we can call this an ectopic atrial bradycardia, right? Okay, that doesn't exclude though that we don't have AV block. And so let's look at our PR interval. My PR interval, which is my AV node function. My PR is within 120 to 200 milliseconds, which is normal. We need to make sure that every P connects to a QRS, and so I scan through all these leads and I make sure, are there any P waves that are hidden on T waves? And remember, P waves are usually these sharper deflections, where T waves are these nice gradual deflections. And so I don't see any extra P waves, and so that tells me there's no AV block. AV node is working. And so far we've got an ectopic atrial bradycardia. Once the AV node gives that signal down to the ventricles, it creates our QRS complex. We have a narrow complex rhythm, right? My QRS is less than 120 milliseconds, tells me it's taking my rapid conducting His-Purkinje system. My axis of my QRS is upright in lead 1. It's isoelectric in AVF. So it tells me it's going towards 1 but perpendicular to AVF. So if AVF is this way, my QRS axis is probably straight left. So that's within normal limits. I would be okay with that. I look for R wave progression. You can see I don't have much of an R wave here, but you can see V2 kind of gets taller and then it gets less tall in V3. That is never really a normal finding. I bet this is poor lead placement. Poor lead placement. Right? That doesn't happen. We don't just get V2 all of a sudden bigger than V3. So sometimes with body habitus, people put things just in the wrong spot. That's okay. Right? But otherwise, we get that transition here to those tall QRSs in V6. So might need to recheck lead placement here. Last thing we're going to do is we're going to, for this kind of ventricular aspect, we're going to look at our QT interval. You can see my QT. It appears to be, if I measure in between two R to Rs, midway point. The T wave seems to be within somewhat normal limits. Last thing I'm going to do is look for any ischemic changes, right? Someone's got an ectopic atrial bradycardia. Well, could a ischemic event have caused this? So I look for ST or T wave changes for acute events. Luckily, I don't see any elevation or depression. I look for pathological Q waves that tell me if there's been a previous myocardial infarction. And you can see in V1, we've got these deep Q waves, but I'll be honest, in the setting of V2 being in V3, kind of this misplacement, I would like to get another one to see. I bet you that V1 is also a little bit misplaced. So otherwise, what do we have here? Well, we've got an ectopic atrial bradycardia at a rate of 43 beats per minute. And otherwise normal ECG from the rest of the electrophysiologic axis standpoint. Now, a couple things, we need to think about: why is this person having ectopic atrial bradycardia? Why is their sinus node not controlling this rate? Well, this person might have something called sick sinus syndrome, and what that means is that their sinus node doesn't beat very well, right? What could cause their sinus node not to beat very well? Often, a lot of times, it's people that have chronic AFib. So people that have chronic AFib, what happens? We get all these fibrillatory waves all the time in the atria, and it just continually stimulates the AV node. The SA node. The SA node gets overstimulated by these fibrillatory waves. It's just depolarized over and over and over constantly. So whenever these people go into a non-AFib rhythm, a lot of times that sinus node is just not doing well. It's not a great pacemaker. So that's actually what happened with this patient. They've got sick sinus syndrome from long-standing atrial fibrillation. So I hope this helps. If you have any questions, put them down in the comments. I really hope you enjoyed some of the learning content from this video, and if you did, please feel free to subscribe to the channel and help support us as we grow. So have a great rest of your day. We'll see you on the next ECG video. Take care.